In a moment, Dr. Stephen Davis will introduce our guest speaker, Dr. Ebony Boulware. Dr. Davis is a Theodore E. Woodward Professor of Medicine and Professor of Physiology, as well as the Chairman of the Department of Medicine, University of Maryland School of Medicine. Dr. Davis is also the Director of the UMB Institute for Clinical and Translational Research and the Vice President of Clinical Translational Science at University of Maryland, Baltimore. Thank you, Dr. Davis.
Thank you. Thank you, Wanda. So welcome everyone, because this really is a red letter day in the ICTR calendar. And I hope, can everybody hear me okay? So it's my real pleasure and delight to welcome Dr. Ebony Boulware, who is the Eleanor Easley Distinguished Professor of Medicine and Director of the Duke Clinical and Translational Science Institute. Ebony is also Vice Dean for Translational Science and Associate Vice Chancellor for Translational Research in the School of Medicine at Duke University. And she also serves as the Chief of the Division of General Internal Medicine in the Department of Medicine. Ebony went to medical school at Duke and then came to University of Maryland, where she did her internal medicine residency. She was a chief resident here, and then went to Hopkins to develop her career in general internal medicine. Ebony is a world expert in disparities in underserved and underrepresented minorities, specifically, especially African American. She's also a world authority in chronic kidney disease, and she'll be talking about kidney disease tomorrow during Medicine Grand Rounds. Ebony has over 170 total publications, seminal book chapters, really important papers, and we really are looking forward to her as part of her Pinkoff's visiting professorship here at University of Maryland. So Ebony, wonderful to see you again, and thank you so much.
Thanks so much. Can you hear me?
Yes.
Great to see you all, and I see a lot of familiar names, at least in the participant list. It's always a challenging giving the webinars, but it's really a pleasure to be at University of Maryland and also at Hopkins in this venue. Both, you know, I feel like I'm still a Baltimorean, although I don't have the accent, and but it feels like just yesterday I was there, although now I've been here for several years. And it's really a pleasure to talk to your Translational Science Institute about some work that we're doing at Duke in the area of data democratization. And so what I thought I would do is give the presentation and hopefully have plenty of time for us to share, oops, I wanted to share my screen, but to share some ideas here. So let me share my screen. Here. Okay, let me share my screen. Hopefully you can see that, and I'll put on the presenter view. And I won't be able to see, I do welcome questions for sure, and there should be plenty of time for us to have some dialogue back and forth. But if somebody feels that you also have something urgent, you can feel free, if somebody would let me know. I can see the Q&A. So if there's something urgent, please let me know, and I'm happy to pause. What I'm going to be talking about is democratizing health data to improve community health equity. Some work that we've been doing over the past many years, 7 years or so at Duke to democratize health data for our community. And I'm hoping to have a dialogue with you to see what you guys are doing in Baltimore in this arena, and see if we can share ideas. So some of what I want to talk about are the premise of why we're doing this, and it has to do with the challenges of translating research and health kind of learnings into community health improvement. I want to talk a little bit about what we're doing in Durham, North Carolina to use our health data to help advance community and population health in our region. And then I want to talk about some of the next steps that I can see on the horizon, and have us maybe jointly talk about how we could move forward as a translational science community in that regard. So first, what I think we all have seen maps like this. We obviously do. We see them actually right now with COVID, that there are always aggregate health effects that seem to aggregate unequally across the United States in regions. And this slide just shows hypertension hospitalization rates per 1,000 Medicare beneficiaries from 2013 to 2015. It was data that came out of the Centers for Disease Control. And it just shows that, you know, hypertension hospitalization rates are much greater in the Southeast and the East, in that zone, particularly in the area where we think of the stroke belt. And we would see this kind of over and over again for many chronic conditions, in particular, hypertension, diabetes, cardiovascular disease. And the question is, why do we see this clustering of conditions when we have, particularly with the case of hypertension, a condition where we have efficacious and effective treatments? So the evidence is there, we have the treatments, yet we still continue to have these inequitable distribution of hospitalizations and chronic illness in particular regions of our country. And it brings into question, you know, is it just the people? Are they just predisposed? Or is there even a role of the social and environmental context, since we see this clustering? And then how do these things kind of interact with one another? These are some of the key questions I think that we're always talking about, and they've actually come to light, you know, much more even with COVID recently, as we're seeing kind of health inequities clustered in specific areas of the country. I think part of what the premise for this discussion is, how do we get evidence-based practices out into the community? And what are some of the reasons that we aren't getting them out into the community? Is it because we're not disseminating the evidence-based practices to providers or health systems? Is it because the individuals who become patients in health systems have preferences to take treatments or don't take treatments? Or is it because of the environmental determinants of health, including structural impediments to healthcare, which could include health insurance access, it could include transportation capabilities, other types of societal systemic impediments that keep people from getting healthcare? But there's something in the translation. When we talk about translation, we have treatments that have been demonstrated to work. Why are we not getting full uptake into the community and improving community and population health? Well, we're all talking about social and environmental contexts around health, social determinants of health, and increasingly we're just having that dialogue day in and day out. COVID again has brought that as well to the forefront. And I bring up this map, which shows the neighborhood disadvantage. And this is a scale that includes about 11 indicators, national indicators, that tag neighborhoods as being either most disadvantaged or least disadvantaged. And the number of indicators include things like housing in an area, education, income, a number of different indices that go into tagging a specific neighborhood, usually at the census block level, according to the amount of disadvantage that it has. And one of the things I think are just striking about this map are we see that disadvantage again clusters in specific areas. Actually, it's very similar in some ways to the map that we saw with hypertension hospitalizations. And in another way, as I think about even the COVID maps, even this middle section seems to kind of reflect that, where we have disadvantaged regions. The other thing that I think is notable about this map is that you've got, you know, little blue areas just next to little red areas. So it speaks to sort of the fact that one's neighborhood, even at that level, actually could have be profoundly different to a neighborhood that's just next door. So that it's not just that our large region has an impact, but also our local environment has a huge impact on the quality of our existence. And we know that these influences have a big impact on health and well-being. This is a depiction I like to show comes from the Robert Wood Johnson, their county health rankings model, and just shows that if you think about people's length and quality of life, they sort of pose that physical environment, social and environmental factors, clinical care, and health behaviors all contribute to length and quality of life. They focus on things like physical environment, including air and water quality or housing transit, and then things like social and economic factors, education, employment, income, family, and social support, as taking up at least 50% of, accounting for at least 50% of the determinants of one's length of life and quality of life, versus clinical care only accounting for 20%. And really emphasizing that it's policies and programs that end up influencing health factors that ultimately end up influencing health outcomes. So when thinking about the health of a whole community or a population, we can't only just deal with the individuals and their behaviors and target that. We really need to think more broadly about accounting for people's environments and the historical local community contexts. So that would include the economy of a region, the built environment, the availability of healthcare services, housing, safety, and as well as people's sort of demographics, including their own socioeconomic status, education, income, etc. So the question is, I think that the translational question for this is really, how do we accelerate getting innovations? In the case of hypertension, there may be innovations that have been around for a long time, but how do we get them out of the ivory tower into the communities for tangible improvements in health? And a few years back, several years back, I attended a meeting at NHLBI. It was really beginning to focus on the social and environmental determinants of health. And some colleagues from Hopkins were there with me, thinking about the next generation of work to target health inequities, and this concept of T4 translation, which is sort of in the area of disseminating and implementing evidence-based practices to enhance their effectiveness. And there was a one-day meeting at NHLBI, and the participants were research leaders and health system directors, government agency leaders, and sort of just a think tank, and talking about what's needed at the next level. And basically, there was just a long discussion about how complicated it is to really target community and population health, because these are complex problems. The problem of lack of translation is so complex. It's driven by people's unequal access to resources, knowledge, and power. And these social determinants, which are reflections of that, including housing, education, employment, they're critical to address, but they're difficult to address, especially in our traditional context of scientific discovery, where we think, okay, we develop a drug for a problem, and we can give that to an individual, therefore we can hopefully treat that problem. Well, what we're finding is that very individually targeted approaches don't work. And then we still seem to, they may work on individual basis, but broadly at a population basis don't seem to work, and we don't have the penetration at the community and population level. So there's this need for more creative, interdisciplinary, transsectoral, and multidisciplinary approaches, meaning we can't just solve these from within science, from within healthcare. We need to involve other sectors. And so in that meeting, the recommendations were to embrace broad and inclusive research themes that incorporated multi-level factors. So not just thinking about treating hypertension in the context of the individual, but hypertension in that individual within their community, addressing the contextual needs that they may have. For example, developing transdisciplinary research platforms that promote system science approaches so that we could approach a problem like hypertension from multiple different angles. Developing networks of collaborators and stakeholders to launch transformative studies, using new data forms, platforms, and natural experiments, and building research capacity. And so when I thought about those recommendations, I thought about, well, what are those kinds of platforms? What does it mean to have system science approaches? What does it mean to have networks, to develop networks of collaborators and stakeholders? And what are these types of new data sources, platforms for natural experiments, and how do we build research capacity? I think that those recommendations are excellent, but they're a tall order. and something that needs to be built over years and years, something that cannot be done in very short order. So one of the things that we've been really thinking about, and a lot of people have been, is how to really focus on who will actually drive changes when we need changes to occur in the community. We work within the healthcare and the public health arenas, but there are other stakeholders in health that actually we need to partner with if we're going to accomplish community and population health improvement, including our business sector, our education sector, nonprofits, community development organizations, and the government. They all play a role to some extent in the health of the community. For example, businesses are employers and have to do with health insurance and healthcare coverage benefits. Educators will educate our community on health behaviors and what to do and what not to do, also empowering community members so that they can have more access to resources and opportunities that will ultimately influence their health, including their employment capacity. Nonprofit and community development organizations often provide services in the community that are specific to those community needs. And of course, government plays a huge role in supporting the health of the community. So when we're looking to produce large community and population health changes, we can't seek to just do that only through our healthcare and public health resources. We really need all of these sectors involved. Thinking about our role as academics in science and in healthcare, we began to think about how can we as a health system partner in solutions that could help improve community and population health. And one of the things that we've been really focused on is our data and how that could be used as a resource and leveraged as a resource to help our community improve its health in partnership with us, in partnership with our community. And one of the things that we've been looking at are our data, and I'm sure that you are also looking at your data. We, of course, collect a lot of data in the process of healthcare, and increasingly we're realizing that we should also be collecting information on social and environmental determinants of health, because those are clearly important influences on our population's health. The data that we collect actually has a lot of value because it actually is direct measurement of indicators of sickness for the most part. But that data is not readily available in the public domain. So it really is an asset that could be leveraged to improve community health, but it's largely under-leveraged right now. It can be mapped and aggregated to identify common health challenges in specific locales, even down to the neighborhood level. It can be used to quantify health inequities across a population, and it can be democratized. So it can be made available so that others can see it in aggregate and utilize it to improve activities to improve community population health. So I'm going to talk a little bit about how we've been doing that at Duke. And first, I want to just give you some information about Durham, North Carolina. It is, this is where Duke University is located. It's North Carolina is 36th overall health in the United States. Durham County is the 6th largest county in North Carolina. We've got about 300,000 residents, so it's small compared to a place like Baltimore. It is ethnically and racially diverse. And it's socioeconomically diverse as well. We have 16% of our population below poverty and 20% above 100,000 annual income. And remember, we're in the Research Triangle Park. It's an interesting area because it's a metropolitan area with some rural area mixed in, and then also some, two major academic institutions, University of North Carolina in Chapel Hill and Duke, within a 5-mile radius. So there's a lot of highly educated, and there's also other research organizations here. So there's a lot of highly educated population here as well, but also a mix with poverty. We have in Durham County, there's sort of a unique situation where 2 health systems provide care for between 80 and 90% of the Durham County residents historically. Duke Health, which is our academic health system, provides care to our county, but then also we have a federally qualified community health center called Lincoln Community Health Center. And Both health systems are committed to improving community health with a long-standing history of collaborative engagement, to the point that we actually share the same electronic health record platform. Duke and Lincoln have an agreement to share our Epic platform, Duke's Epic platform, to deliver care to all the people. So between the two health systems, we believe 85 to 90% of population of our geographic population in our county actually have data in the electronic health record. So in 2016, we established a joint effort with our county public health, Lincoln Community Health Center, and our Duke Health, with a nonprofit organization called DataWorks, which is located in Durham, to take our health data from both health systems and democratize it to inform health priorities. And when I say democratize, what I'm saying is that we agreed to aggregate all of the data within our health systems at the neighborhood level by race, gender, ethnicity, and age groupings, and then break them down to at the county level, the census tract level, and the census block group level, so that we could provide that to our county public health, who then would make that available to public stakeholders to view, to get a snapshot of what was happening in terms of health in Durham County. And so this is sort of the workflow, and I'll show you some examples of this, but what happens is that individuals receive health care in one of our two health systems, and then there's a reporting process whereby aggregate reports of the prevalence of different health conditions at the neighborhood or the census block group level are provided to the county public health. And then that information is provided to this public nonprofit, which then publicizes maps of health based on the data that come from the two healthcare systems. And then the idea is that these data, and they are available for community stakeholders to view and use them to help them in their efforts to improve community population health. So this on the left is sort of what our map looks like. You could go to it if you want, even right now. It's called the Durham Neighborhood Compass. This area in blue is an outline of the geographic region of Durham County in North Carolina. I think Duke is down in this area, I think over here. And what we've done is we've created some maps on a number of different health conditions of individuals who've received healthcare at Duke or at Lincoln at the neighborhood level. So this particular map that's being shown is the diabetes prevalence in 2017, where darker areas indicate greater diabetes prevalence at the block group level, and lighter areas are lower diabetes prevalence. And we have similar maps for stroke, myocardial infarction, chronic kidney disease, obesity, preterm birth, and low birth weight. And those maps are available under the health tab of this website. And somebody's asking, Byrne is asking, is this information available to non-stakeholders? Yeah, it's publicly available. So you can go to it right now, this compass.durhamnc.gov. So the website the information is available. The data are actually downloadable in aggregate you can get it in Excel tables, spreadsheets actually. And so what we've been doing is providing these reports to the county public health, which then gets it to the people that run the website, and annually update them as well. So the other thing that's really neat about that is, so we provide those maps, but there are also other maps on the website that capture elements of social and environmental determinants of health, including things like civic engagement, which would be including things like voter participation, other demographics, of course, income, race, ethnicity, educational opportunities. And I'll show a list. Information on the environment, health, housing, infrastructure and amenities, and safety. And what this is, so here are, this is a map of housing evictions, ejectments per square mile in 2018 by neighborhood. And this is a map of violent crimes per square mile in 2018 by neighborhood in Durham. So what you end up having is a juxtaposition of maps with health and these other social environmental determinants next to each other. They're not overlaid yet, but they are juxtaposed with one another, and that data can be combined. So here are the kinds of data that are in these in the maps. So for civic engagement, the data elements are general election participation and primary election participation. There are a bunch of demographics. Oh, one thing I wanted to point out, the reason I'm actually showing this is that these data, yes, so everybody will say, yes, I've seen this kind of thing before. We know that we have data from the American Community Survey and the US Census, and you can get some of this. But what's unique about this, and this would be unique for every specific region that would do this, is that some of this data, a lot of this data comes from our local data that you can't get elsewhere. So from our county board of elections, from our city and county inspections department, from our county tax administration, from our police department and county sheriff, our neighborhood improvement services. So it's not just that we have these data from the American Community Survey, which everybody can have access to, or the census. We have local contextual data that you can't get elsewhere that gives you more of an accurate depiction of what's happening in the social environment locally. So this would be, you'd have different data sources for your area. And in fact, if you look at some areas like New York City have a tremendous effort going on to democratize all kinds of data that are publicly available on their websites. That could also be used in similar ways. Someone's asking me, is there a similar effort for mental illness? We'd like there to be. We haven't gotten there yet. There are some conditions that we haven't yet tackled, and part of it is that we're about to do some community listening sessions to really understand how people feel about specific areas, the types of conditions that they want to have, that the community wants to have or wants to have publicized. And then somebody's asking me also about, can we share more if and how the community is involved in determining which metrics to measure and map? The community is involved in this effort, so that the people that run the Durham Data Compass are constantly doing community listening sessions, getting community input on what's on that mapping and the website. There's actually quite a bit more on the website. There's some very interesting depictions of data on the website that are community led. So there are these almost pictograms of what's happening in your neighborhood. So if you live in a high crime neighborhood, they may show a picture of a neighborhood, and then they'd show like a police car there. They might, if you live in a neighborhood where there's a lot of walking green spaces, they'll show somebody maybe pushing a stroller down a green space. So they've been working with the community on how to depict the data as well as what goes into the data. It's been an interesting process seeing how the engagement has been ongoing. We're also engaging the community, and I'll talk a little bit about that, but how to, in terms of what health conditions should be shown, how they can be shown, and how people want to use it. I'm going to move. Here's some more information. So the kinds of data that we have on housing, the kinds of infrastructure and amenities that are there, on safety information. So as I said, I think what's distinct about this is that this is our local context, but if you go to a lot of other communities, there are efforts to democratize this type of community data across the country. Robert Wood Johnson Foundation is helping lead a project. There's this 500 Cities project where people are really working to get neighborhood level data, making it possible to look at some of these social environmental contextual determinants there. New York City has an amazing effort to democratize all of their data. And what is not quite yet happening is the combining of that data though with the health data, because what we really want, at least from our perspective, is how do those things influence health? So that's what our effort has been trying to do, and we're beginning to think more and more about how this can be used, not only to democratize information about health for stakeholders use, but then also how we can use it for research internally, and then continue to contribute to the public dialogue. Here's an example of one way that we've begun to think about this in terms of research. I have some ongoing studies with a colleague of mine, Danushika Mahatage, looking at chronic kidney disease and its prevalence within Durham County. And again, we see differing prevalences at the neighborhood level. And we've been interested in sort of understanding, are these social and environmental determinants associated with CKD prevalence? And this is some older data. Our work is ongoing. We've presented this a little bit at a couple of times at a couple of meetings, and we're writing the paper right now. But we went through and looked at neighborhoods. There are about 150 neighborhoods. And some of them we categorize as being high prevalence, and other neighborhoods as low CKD prevalence based on the median prevalence in that neighborhood. And we sought to understand were any of these social and environmental determinants associated with CKD prevalence, higher versus lower CKD prevalence, and found that some of these preliminarily are associated with higher versus lower CKD prevalence, including violent crimes, commute times, social cohesion, and household income. And so that has really begun to have us thinking very creatively about these social and environmental determinants and how they may or may not relate to the kinds of outcomes that we're trying to improve, and the kinds of interventions that might need to be implemented to improve kidney health in our community. And then taking it even a bit further, we've been talking at the neighborhood level. Danushika is now also thinking about going into neighborhoods with high CKD rates and looking at the microenvironment. So there are, in the Southeast in particular, I don't remember this as much in Baltimore when I was there, there's the use of low cost, high potency non-steroidal analgesics, like BC Goody powder. And those are very highly used in, especially among lower income populations. And she's interested to looking and seeing, are they actually being marketed in retail outlets in high versus low CKD prevalent neighborhoods. So she's going to be doing some mixed methods work, including environmental scanning, plus looking at purchasing data to look at how these nephrotoxic, these kidney toxic medications might actually be marketed within high versus low CKD neighborhoods, getting a little bit more at some of the drivers of community and population health and health inequities. She's also interested in looking at sort of where these types of kidney toxins, the NSAIDs might be sold, convenience stores versus liquor stores versus tobacco and vape versus pharmacies and supermarkets, and looking at that. There are other things that could be interesting to look at. She's actually obtained purchasing data. So that work's ongoing. And it's just interesting when you start thinking about the environment, about where people have to go to get their food or get their medications, or, you know, and what's available to you in your region. So beginning to look at the retail and purchasing environment. That work is ongoing. In the meantime, at an institutional level, we're interested in also linking these data, not just the American Community Survey, but these also local contextual data to our electronic health record data. We've developed a clinical research data mart that includes data from all of the individuals receiving care at Duke and at Lincoln Community Health Center into a common data mart that essentially is built off of the CoreNet data model. And these data now we are actively linking to, all of the individuals in the data mart are geocoded, so we have geo identifiers, but now linking them to multiple data sets, which we're calling a social determinants of health sidecar that links into that, so that every individual within the data mart actually has these individual data elements linked to it, so that you can do patient level analyses that can also be aggregated at the community level to look at the influence of social and environmental determinants on health. our data, we've got also a data science, big push for among data scientists here on campus. And they are very interested in linking data, further data on marketing, traffic data, social media data, and other kinds of data to these types of data. They note that there are a plethora of different types of data on people's behaviors that come through purchasing, since people are using so many credit cards or debit cards, et cetera, and really interested in linking that kind of work to health as well. So there are other opportunities. We're not there yet, but this is what people are really discussing. And so, one of the things I think that this kind of opens up are how can we leverage our electronic health records to then identify social and environmental contexts that might lead to improved health, and then thinking about how we might tailor interventions for people based on their social or environmental context. Are there ways also that as we become more data savvy and are able to link data to things that might be available, including web search strategies and things, to head off adverse events like suicides or unintentional toxin ingestion or violence or trauma? And then what intrigues me also is how do we figure out how to move, whether our health policies or the things, the interventions that we're doing are changing over time. In the compass that I showed you, we are providing updates to the data over time. So ideally, we would be able to see, okay, well, we've been investing however many millions of dollars into improving diabetes care in our region. Are we moving the needle? Is health actually improving? And so that we can begin to think about sort of the collective effort that's going in to improve health and whether we're actually improving health. I have yet to see people show that kind of longitudinal analysis as to whether or not we're improving health over time in populations for sustained time periods. So the idea that we can leverage our health records to do that intrigues me quite a bit. So as I said, we continue to do annual updates to the community so that the community has access to this. And the other thing is that we are doing the sidecar, as I mentioned. We are actually, though, not just leaving it there, we are engaging our community around these data. So we are pulling in, somebody asked me about what stakeholders are we thinking about. We're talking about people from our county government, from our education sector, from the religious sectors, from our nonprofit health organizations, and other sectors to really come and sit with us and talk to us about using this data and whether it's useful. We've unveiled it in a number of community health forum, and there's a lot of excitement from the community about having access to these data, particularly the community-based health organizations, which don't normally have access to this kind of information about what's happening on health in the community, are very excited about using it. But what we want to know is how to even make it more accessible, more useful. What kinds of functionality should something like the Compass have that we can enhance its usefulness to the community. We also have within our CTSA developed some Sparks pilot awards so that community members could actually propose new ideas along with researchers on the kinds of studies that they might want to have done to get research and activity going in the community. So we're trying to engage with our community, not just providing the data, but also trying to work collaboratively to see if this can be leveraged to improve health. And when I'm thinking about next steps and where can we go from this, I don't know if everybody is aware of this, but there's a larger there's sort of an effort. So in addition, obviously you have your healthcare, your electronic health records. There are also these national efforts to link everybody's health records, all these systems health records together through, one of them is through the CTSA network and at NIH. But there's this thing called there's two efforts that I believe that are linked. One is CD2H, and I'm blanking on the full name for CD2H, but that was the initial effort to link at least the CTSA organizations together, all with their health records into a common sort of federated model where data can be shared in a cloud, essentially, to make data discoverable across multiple different health systems. And it actually got a huge boost when COVID came along. There's this, now it's the major effort is this National COVID Cohort Collaborative. So that's linking multiple different organizations together under a data partnership and a common governance model to harmonize data from across multiple different efforts, so that you could actually look and identify cohorts within these data, build cohorts, and ideally ask important questions across multiple health systems. My thought is that if you can link up electronic health records from, you know, over 100 healthcare organizations, you could also have them link in their social and environmental determinants of health, and you could have similar efforts for data democratization, so that this could actually, with this little small experiment that we're doing in Durham, actually could be broadened nationally to have this kind of an effort, so that you could actually have, in addition to that map, just like I showed earlier with the neighborhood deprivation index, you could have maps for across the nation on a number of health conditions. So I'm going to kind of stop there and just say my summary is that health systems, we have an opportunity to get involved in community and population health by, in one way, certainly we can always engage our communities, but we actually have a lot of community asset in the data that we have, and sharing that with the community not only informs the community, but it kind of empowers the community, because then other stakeholders who have other engagement other than just providing the care can get involved and be engaged in collaborative efforts to improve community and population health and drive health forward. So I want to just acknowledge that this work at Duke is involved in a number of different groups, and it's actually taken us quite a bit of time to get this work done. We've been great. Our health system has been really quite helpful in helping us overcome some of the regulatory hurdles to releasing data, and has been willing to really work with the community, which has been quite helpful. Our county department of public health has been tremendous partners. Lincoln Community Health Center as well. And a number of other groups at Duke helping to make the effort happen. But there are a lot of exciting possibilities, and we continue to try to build on it. So with that, I'm going to stop sharing my screen, and I'd love to see if there are any questions or comments. So I saw some, so I'm going to try to go back. So is this data, so there's one question that says, is this data being collected in a similar fashion around the country in terms of ease of implementing data democratization? It would be amazing to use your well thought out framework elsewhere. Well, thanks for that. Saying, I think what's interesting is that the collaborative, what had to happen in terms of the collaboration to get this done actually was many years in the making and many, many meetings. The terms of the data, some of the data from the census and from the American Community Survey are clearly publicly available. So yes, but what has to happen locally is that, for example, your data on crime, your data on early childhood education, your data on housing quality, on tax parcels, that's all going to be local for the most part. So that's where you have to work with your local municipalities to get that data. I think what would be interesting is to think about, just as we're beginning to harmonize health system data across multiple health systems across the country, what would it take to harmonize this type of data to make it also democratizable in a uniform fashion across the country? I think people are thinking that way. That's coming on the horizon. It may be a ways off, but it's been a huge advance just to get groups to be democratizing all of their data. And I'm interested to hear what's happening in Baltimore with regard to that. There's another question here that says, are you considering initiatives to expand data literacy in the public? Working with public health departments, we found that to be a pressing need. Yes, so I didn't get into this too much, but the this, I alluded to it a little bit. The Compass has a whole segment sort of devoted to showing data in a different way, like not as numbers, but sort of depictions of what's happening. And I find that to be a really, really important. I think the idea of data literacy, I agree, is huge. It's a very pressing community need, because we tend to just show these numbers and people don't know how to interpret these numbers appropriately, and that can be very dangerous. So one of the things that the group has been doing, and it hasn't necessarily been coming from us at Duke, it's been really coming through the community nonprofit, the DataWorks, really trying to figure out how to show the health information in ways that lots of people can interpret, including through pictures, through more narratives, rather than just the maps. And so that's one of the things also we want to try to understand from within Duke is, how do people interpret these maps? Are they interpreting them accurately? What kinds of things do we need to do to help people understand these data and interpret them appropriately? Here's another, Rick is asking, Durham's changed a lot in recent years. Are the indicators of social determinants stable? If not, how would the outcomes of intervening to change the trajectory of a healthy be assessed against such an unstable baseline? Have others figured this out? That is a great question. Durham is changing. It's a place where there's a lot of gentrification happening. There's a lot of change happening. And I don't know about the stability of the social determinants, other than to say, what's interesting is that, just as with other places, I was talking with a colleague earlier today about redlining, and the areas that tend to have less investment continue to have less investment. The areas that have more investment seem to grow. There has been gentrification, but that's a slow process. But you know, there are changes in those social determinants. One of the colleagues that are here, Nupin Bhavsar, he's been looking at gentrification and how that's changed over time, over like an 8-year time period here. I don't know that the area actually is that stable, and there are ways of sort of capturing gentrification rates, and he identified 4 or 5 different measures. But I think that's an evolving area, as to how to figure out how social determinants are changing. And a lot of that determines who's moving into the area, who's moving out of the area. And so he has an interesting study looking at, in his studies looking at gentrification and health. We have this ongoing dialogue. Is an area getting healthy because the less advantaged people are being moved out, so that the people who are more burdened with chronic conditions are actually being moved to the area? It looks like it's getting healthier because there's more investment, but actually there's more investment because there's wealthier people moving in, and you're just moving those who are most burdened by social and environmental determinants out of the area. This is an ongoing area of investigation.
I just want to invite everyone to use the raise your hand if you'd like to ask a question live.
I don't know if anybody's able who's on would be aware of, I would love to hear if there's similar efforts going on in Baltimore that you're aware of. There's a hand raised.
Dr. Unsham, would you unmute yourself, please?
Oh, I'm sorry, I was typing. Yeah, thank you so much for your great presentation. Could you please comment on some of the challenges with including non-EHR data?
Oh, into the incorporating with the EHR. Well,
Yeah.
what we've done is actually, so it's not So these are linkable, and it's sort of a separate data mart. So it actually comes from, so it's a process data mart. So it's updated nightly, but it's basically what we're working through is that it's not embedded into like the actual patient record. It's connected to, so we have a mart that's updated from the electronic health record that then is linkable to the other data. Does that make sense?
Yeah,
So it's outside of, although it's in a protected place, it's not the actual platform that clinicians are actively entering data in at this moment, but it's updated nightly.
Okay, thank you.
So I see. Yeah.
I was unmuted. So I was raising my hand. I'm Dania Cato. I'm a faculty member at the University of Maryland. So regarding your question around efforts that are happening in Baltimore, the Baltimore City Health Department specifically and the Baltimore Neighborhood Indicators Alliance have been really central to collecting and disseminating neighborhood level characteristics and metrics, often on an annual basis, if not more disaggregated over time. But just, I wanted to throw that out there as efforts that are happening specifically in Baltimore that I'm aware of that collect data disaggregated to the neighborhood level that might be sort of in alignment with the work that you're doing in Durham.
Yeah, that's great. Yeah, I think there's more and more of this happening, and I see somebody else mentioning that somebody's mapping data on social and environmental determinants of health to COVID prevalence. I think COVID has really pushed a lot of these efforts forward because of just the clear disparities that people are seeing, the inequities in health, that a lot of these efforts are moving forward more quickly right now, which is really important. Again, one of the challenges is sort of figuring out also how to help the community be data literate, and how to help the community leverage the information that we're providing in the best possible ways that the community thinks are important. Let's see, Rick Barr.
I think we are doing much better in terms of integrating data across, for example, education, child welfare, Medicaid, and the like than we are some of the other local departments like taxation and transportation and so on. So we have some very strong initiatives that are able to follow kids now from preschool to career, but they're really almost all child focused, and I don't know that much about any similar initiatives looking at the adult population. Just to say, the BNIA, the Baltimore Neighborhood Indicators Alliance, has been at this for a very long time, but we still have a big gap in terms of really connecting the neighborhood pieces to all of the other administrative data that describe service delivery and outcomes like standardized tests or transitions to juvenile services or something like that.
When you guys have two health systems now and you're connected through your CTSA, I wonder, are you thinking about this kind of a thing between the two health systems? I would think almost all of those hospitals would be on some kind of connectable electronic health record platform through CoreNet or something. I don't know if anybody's on that can comment on that. Because when I talk to folks in New York City, one of the problems is that they have so many different hospitals and so many different health systems that there are challenges in getting those health systems to talk to one another. Baltimore is another situation where there aren't as many health systems, but it's a large metropolitan area, and it seems there could be a huge potential for the systems to link up there.
I'll just say that, yes, we are working very intensely with Hopkins to be able to link our medical systems. And so that's a real starting point. Less has been done to try to, again, take it to the next ring out in terms of neighborhood indicators, but it's our expectation that in the next couple of years that we will be able to track patients back and forth between the two hospitals and medical systems more broadly, and start to understand outcomes in that way. And then maybe, that's a big swallow. So maybe after we do that, we can add some of these neighborhood indicators.
Yeah, it's a huge undertaking. I do see Patty E. from Hopkins saying that you have your regional exchange, CRISP, which is another opportunity potentially to get that data. It's already in one spot there.
So yeah, so Ebony, absolutely, and following on from what Rick Bath just said, CRISP is a real resource. And as are the 14 hospitals in the University of Maryland medical system, as is College Park and the powerhouse of the public health there. So what we are doing is, first step is to bring all the 7 schools and UMMS together. And that is, we're nearly there. We'll, certainly with electronic medical records. So it will probably be done the end of this calendar year. Then there are MOUs in place with the University of Maryland, Baltimore County, and there'll be one coming up from College Park and Prince George's County, which is absolutely critical, as you well know. That is a very unique county where you have some of the most wealthy individuals in the United States and some of the most underserved. But the University of Maryland medical system is putting up a $700 million new hospital there. So we will link that. Then we will be linked to Hopkins, and apart from a little bit from MedStar, we would have linked Maryland together. Now, Baltimore is interesting because the east side of the city, it's community engagement from Hopkins, which is much more sort of ambulatory care than actually going into the neighborhoods, which is we are, and you're meeting with Dan Mullins and the patients program. But this is one of the things that, and when you pointed out T4, that is driving our CTSA and ICTR, incredibly important. And Dr. Cato is a K awardee from the School of Pharmacy, and we're extremely proud of her. So absolutely, Emily, we look forward to talking more about this tomorrow.
Yeah, very, very exciting. Lots. It's overwhelming to think about all that happening in Baltimore. It's a huge place with a lot going on, but kudos to even pulling, getting it together and moving it forward. So I don't know if our time is to an end here, or.
Yes.